Hi, I am Dr. Sanjay Chugh. I am a senior consultant psychiatrist and I practice in New Delhi. And with me, you are watching Dr. KK's Med Talk Sundays. It's the non-stop show number 692. That's an amazing number. I had a very long association with Dr. KK Agarwal. I mean, everyone called him KK. I also, like everyone else, called him KK. I first knew him as a very close friend's brother. And I still remember the day when I met KK for the first time. He was practicing at Mulchand, and we were still medical students at Maulana Azad Medical College. And, he had already created such a big name for himself. This is 40 years back. So my friend, who is KK's younger brother, he said, let's go and meet my brother. So sure enough, we went there. I was almost quaking in my shoes. And there I saw this person, and that image lasted with me for the next 40 years. One man with a stethoscope around his neck, looking not only intelligent, looking wise, very, very careful with his words, and he knew exactly what he was talking about. And that legend continued, it continued to grow, and he left us with a legacy which has touched not hundreds, not thousands, not lakhs, not millions. I would say it has touched the lives of hundreds of millions of people all over the world. When COVID started, the work that KK did in promoting awareness about COVID, what the disease was, what the symptoms were, what the manifestations were, how it could be managed, it was phenomenal. I know for a fact that over 100 million people were exposed to his wisdom, to his knowledge, to his learning. Even before that, KK had established some crazy records in what is called CPR, cardiopulmonary resuscitation. You know how to give a cardiac massage to a person who is on his deathbed. And he went all over the world teaching hundreds and thousands of people how to do it. I think eventually there also, he taught this to millions of people. For me, he was a teacher, he was a mentor because even though I'm a psychiatrist, he introduced me to the concept of holistic healing. Whenever I would interact with him, whenever I would talk with him, he would tell me that a disease, even if it's a psychiatric disease, it is not only a physical entity. You don't need to treat only the physical part of the illness. There is much more to it. He used to talk in terms of mind, body, soul, and so on. And even today, inside my heart, KK lives on as he lives on in the hearts of millions of people in this country. And today's show is a dedication to the work that he started, that his family is continuing, the trust is continuing. And I salute you, KK, and may you rest in peace wherever you are. And now, can we have the headlines of the day? There's been a single day rise of 16,103 new COVID infections with 31 reported deaths. Headline number two, now documented informed consent is a must before any clinical, any diagnostic, therapeutic, or operative procedure is carried out. And extremely important, eye twitching and other eye symptoms might also be related to COVID 19. It was something which was not understood earlier, but now we know that this could be a consequence of the infection. And now, after the headlines, let's move to the topic of the day, which is to discuss this topic, which is mental disorders. We have a very, very special person with us. She's a special guest, Dr. Jaya Shukul. Let me give you a quick introduction to Jaya. Hi, Jaya.
Hi, sir. How are you?
Good. She's a doctoral researcher with an established background in behavioral sciences. She is a clinical psychologist with a huge amount of expertise in depression, anxiety, irritable bowel syndrome, sleep disorders, and pain. In addition to all this work that she does, she is also the founder of ProGarten, which is India's first clinical career counseling program. Welcome, Jaya, on today's show.
Thank you so much, sir. Glad to be here.
Great. So now, let me give you a brief introduction to what mental disorders are, and then we will proceed with the rest of the program.
Absolutely.
What we are understanding today is that the word mental actually is an outdated concept. Today we are viewing what we call, or what we used to call, mental disorders as brain disorders.
Mhm.
A long time back, over a century ago, an artificial divide was created between neurology and psychiatry, where those wise people of that time, of course, at that time, what they knew best. They said that disorders where we can document a physical cause, I'm talking about the neurological symptoms. So where you can document a physical cause, we will call those neurological disorders. And where a physical cause cannot be demonstrated, it cannot be documented, we will call those psychiatric disorders. Now, as
Yes.
time went by, our ability to do a lot of diagnostic tests, a lot of diagnostic screening increased. We had started with X-rays, then we developed the CAT scan of the brain, then we had the MRI, then we had the functional MRI, then we had what is called the positron emission tomography, which is the PET scan. Now, using these modalities, when we look at the so-called quote unquote neurological disorders, there are very well defined, very well demarcated lesions in different parts of the brain. But today we are realizing that if we look at something like a depression also, and we do a PET scan or we do a functional MRI, there are these same documentable changes present in different parts of the brain. And there is
Absolutely.
nothing to suggest today that psychiatry and neurology are two distinct entities. I don't know when it's going to happen. I don't know if it will ever happen or not. Of course, there are a lot of lobbies at play here. No
Yes.
neurologist is going to say that, a psychiatrist should be able to treat a stroke or multiple sclerosis or Parkinsonism. And conversely, psychiatrists are always complaining that neurologists अपना हर चीज में हाथ दखल देते हैं. They are treating the depressions and the anxieties and the pain, actually, which should be treated by not mental health professionals, but by brain health professionals like Jaya or someone like me. But these differences apart, these divides apart, the fact of the matter is that these so-called mental slash brain disorders today are the commonest illnesses in the world. If you
Yes.
look at cardiology, if you look at the respiratory system, if you look at the gastrointestinal system, you look at gynecology, there is no organ system in the human body which affects and afflicts so many people with disorders as the human brain does.
Absolutely.
There is
Absolutely.
no comparison. In fact, the brain is the master organ of the body. If something goes wrong in some
Absolutely.
part of the brain, it can give rise to a lot of cardiological problems. You can so you can have palpitations, your BP can go up, your BP can go down. If there is stress, it can eventually make you vulnerable to developing a heart attack and so on. If you
Absolutely.
have, let's say, some vulnerability inside your respiratory system, there is some problem inside the brain, you could have a full-blown asthmatic attack.
Absolutely. Panic attacks can also lead to asthma attacks or bronchial attacks, as we've
Absolutely,
seen.
absolutely,
As we
absolutely.
and I think there's a severe underreporting of the mental health, or let's call them the brain disorders, as you rightly put on. There's a severe underreporting, as you would see. You would see people in cardiac sciences, obviously, with well-defined brain disorders, but not getting the right treatment or not getting the right approach of the treatment as well. Like a lack of holistic approach in the medicine creates this. Underreporting, and it continues the suffering and the misery of the patients who live with brain disorders, I feel. At least that's what I felt in my clinical practice.
See, there is underreporting, which is essentially arising out of a lot of misconception and a lot of stigma which surrounds all these entities, these disease entities or these disorders. Now,
Yes.
I have been in practice for about 35 odd years. The amount of misconception that I used to deal with 35 years ago, I would say it has gone down by maybe even
Significantly.
70%. There's a significant
Significantly.
decrease in the misconceptions. There's a significant decrease in the stigma. Now, people are not reluctant to say, oh, I have Dr. Chug as my treating doctor.
Yes.
30 years
Yes.
back, people would meet me at a social gathering, वो आंखें मोड़ के वो मुड़ जाते थे कि अगर कोई
हम तो
देखेगा जी
नहीं जानते.
डॉक्टर स्माइल कर दिया, डॉक्टर चुग has acknowledged me, how do you know Dr. Chug?
Yeah, I
So
think
these are all-
huh. I
go
I
on.
I too only I've been here only for 10 years, but I think in my initial years of practice and then the last 2 3 years also that number has rapidly decreased. You know, people have actually started acknowledging mental health, acknowledging going to psychiatrists, going to mental health professionals of varied kind. I think it's finally the time that maybe we'll be able to help as many people as we should, and you know we're trained to do so.
Absolutely right. So having said all of this, I want to thank the Dr. KK Agarwal's foundation, his family, the trust that is doing this. It's for me, it's a kind of continuing education program for the masses. And it's a
Absolutely.
brilliant idea to say that, okay, you have doctor's day once a year, but one doctor's day is not enough to not commemorate really, but to do justice to all that should be spoken about. And so a doctor's week seems to be a wonderful idea.
Absolutely.
And
Absolutely.
having said all that, Jaya, let's you and I go through a list of the most Googled questions, which is again a
Yes.
unique idea. Let's take a look at the most Googled questions where psychiatric or brain related problems are concerned, and let's see if we can shed some more light on these topics more than what people already know.
Absolutely,
Shall we
sir.
start?
Let's get, yes, absolutely, sir.
Great. Okay, so the first question, which is the most common question which people would search for on Google, are these disorders genetic in origin? Let's have your take on this.
So the first thing is, I think this is such a brilliant question to start with. Yes, there are genetic predispositions to all brain disorders that is present, but one thing that we often forget is that these disorders are the one that have developed through childhood and gone into adulthood. And for example, if I have a parent who's been clinically depressed, let's say, or who's been persistently depressed, then the home environment, the learning environment is something that is going to be reflective of that disorder itself. So sometimes, even if you don't have the genetic makeup to get depression, but your environment, there's always that fight between nurture and nature. But if you are being nurtured in an environment which is, let's say, influenced by mental health issues, then there is a chance you will also develop those brain disorders or those mental health disorders, because that's what you've learned, that's what you've subconsciously processed, that's the learning patterns, that's the coping patterns that you've learned in your environment. Uh, so yes, there is a genetic predisposition available for most of the brain disorders, but the most important thing is the nurture, is the environment that we've grown up in. So if a parent has had mental health issues that has been left untreated, it is likely because the child learns subconsciously through the childhood experiences that they will develop all of these disorders, or there is a risk of developing such disorders as well.
Excellent. I would like to add a little bit to this. Now, if we take the same example which you've stated, that there is one household, let's say one parent has some psychiatric problem, some psychiatric disorder, or there's it is affecting the environment. If there are two children in that family, the chances are quite high that only one of them would grow up to develop the disorder, or one would develop one kind of disorder, the other child might grow up to develop a different kind of disorder. What this reflects, according to me, is what we call a biopsychosocial model. Let's say there's a triangle. So at the apex there is the biology, which is your genetic makeup or your internal environment.
Yes.
Psycho is psychological, which let's say is your personality makeup.
Yes.
Social is your external environment, which is the nurture that you're talking about.
Yes.
Essentially, I would say that all these disorders are an interplay between your bio, psycho, and social components.
Okay.
And in the absence of the bio, that means in the absence of the genetic vulnerability, you will probably not end up developing that particular disorder. Whereas if that genetic vulnerability is there, then things in the external environment, in your nurture, things that are happening in your life, maybe you're facing stresses and all, then they have a much higher chance of triggering off
Exactly.
a certain disorder
Yeah.
than if the genetic vulnerability had not been there. So,
Absolutely. What
so
we call the genetic disposition is always, waiting for a trigger, and that trigger can come from the environment itself.
true. I would say it holds true for every disorder. I mean, if you look at hypertension, you look at diabetes, you look at a whole variety of disorders. In most
Mhm.
cases, it is very easy to find out whether there's a family history of hypertension, whether there's a family history of diabetes or not. But where our disorders are concerned, most people either are not aware of them or they're reluctant to talk about them. So again, there is an underestimation, underreporting, and so this false belief that maybe genes do not have an important role to play. But the fact
No,
of the
but
matter is that the genetic makeup is extremely important.
extremely important. That's what, if I have a minute, I would like to add on that when you say that two children in a house but will not get the same disorder, it's also because their genetic makeup in the same environment, their nature is obviously different, but the nurture is also different for two children. For example, when the first child was born, the parents, it was the first child, it was just a one child household. But the second child was born, there was a two child household. So again, the bio changes obviously because of the genetic factors at play, but also the socio and the psychology keeps changing. So these psychosocial models become a triggering agent, but that does not underplay, let's say, the genetic disposition that is available. If the genetic disposition is resilient to such conditions, I think it takes a heavy trauma to change that. But unless you're resilient biologically, then you have become more resilient in your psychosocial environment as well. Completely agree
So,
on that.
absolutely. So here I would say that the resilience also, or the ability to handle adversity, is also genetically determined.
Absolutely,
It is the
absolutely,
genes which will determine how resilient you are to different changes in your circumstances.
absolutely.
Right? Okay, so let's move on to question number two. Can anger issues be related to mental disorders?
Absolutely, absolutely. I cannot even begin from where all anger can stem from. I always believe to say that anger is just a mask. Anger is a symptom. Anger is it's a very rare that anger itself is going to be a disease. Obviously, you could be hormonally predisposed. You could have a genetic makeup that makes you more rageous than all the other people. But in a lot of situation, anger, I feel, is just a mask. It's just a symptom of an underlying problem. We see people who are unable to express their emotions adequately, or who feel frustrated, who are neurodivergent. These people, have so much anger, and anger is not just one box. Anger can be a symptom of multiple forms of brain disorders, multiple forms of underlying situations, which could again be biological, they could be social, they could be psychological, or the three of them combined. So anger just in one category is not enough. Yes, we can make a diagnosable criteria, we can go to the books, we can say, okay, yes, you have like a major anger related problem, but anger even in the smallest forms, in the smallest phases, also reflects underlying issues. And I think it's very, very important to address it, that because now I've seen people come up and they say that, oh, we've always been angry, it's our personality to be angry. Or my father also used to be very angry, my mother also was someone who used to remain angry. And somehow it's made to be felt normal that गुस्सा करना तो चलो normal बात है, सबको ही आता है, इनके घर में तेज गुस्सा ही चलता है. But anger does not only hurt the one who is angry, but anger hurts the environment around us. It might hamper our parents, it might hamper our children, any form of relationship, personal or professional, or our everyday functioning gets hampered by anger. So it's time we start looking at anger as a symptom and not just as a disorder itself. And let's not normalize anger to great extents that it continues let people suffer in silence. Let's not normalize being angry generationally as well.
Very, very good. I agree completely with what you're saying. I'll just add one more thing here, that
Absolutely.
if we look at irritability and anger, essentially the key here is you use the word frustrated or frustration. People who can tolerate frustration are not going to get irritated. People who have a low frustration tolerance level are likely to get irritated. And if your frustration tolerance level is even lower, then that is more likely to lead to anger. And
Yes.
then that brings us to an entity called impulse. Now, let's say you do something which I do not like. I want to shout at you, I want to scream at you. It's an impulse which is coming up within me, but most people would be able to control their impulses. However, there is a certain subset of people who have a problem with impulse control, and they are more likely to manifest that anger as opposed to people who have good impulse control. So I think it's a combination of low frustration tolerance and poor impulse control, which leads to the anger outbursts. So
Absolutely.
if you say, or if the question is, are they a manifestation of an underlying disorder? You say yes, I say yes. So both of us are in consensus there.
Another point I would like to add is that anger is an emotion and it becomes a disorder when it turns into a behavior. And I think that's a quote I read, I don't know where, but it's always stuck with me. As an emotion, anger is fine. All of us agree, have it. All of us are bound to have it. It's a part of the normal. But the moment it starts taking a toll on our behavior or it turns into a behavior, let's say, as you rightly said, that if you have an impulse control problem, it will turn into a behavior. It could lead to an action. The emotion could be led to an action, and that's where it does get into the criteria of being a disorder per se.
Absolutely right. Great. So we have, I think we've addressed this question adequately. Let's move on to the next question today.
Yes, sir.
The third question is, does depression cause memory loss?
Yes, depression
Your
does
thoughts?
cause. Yes, depression does cause memory loss. It significantly affects the declarative memory, which is the memory regarding facts and events. Uh, Memory loss could be of different forms as well, short term, long term memory losses. It sometimes also slows down the creation of nerve cells where we're unable to form new memories or recall memories as well. So, depression, yes, leads to memory loss in different ways.
Absolutely right. You have said this in a very, very concise form. If we look at memory, like you said, there are different components. The first is the initial registry. You register something, something has happened to me, then the brain wants to retain that information. And finally, when the time is right, you want to recall that information.
Mhm.
With depression, there are probably problems at all three levels. One of the
Absolutely.
predominant symptoms of depression is a lack of attention and a lack of concentration.
Good
So,
concentration.
if you are not able to concentrate on what's happening, then the registry or the registration of new events, new inputs, new raw materials, that is impaired. Now, what you have not registered, you will not be able to retain. Plus, like you said, there is a problem at the neuronal level, at the level of the nerve cells. Maybe the nerve cells which are required to be created to retain this information, because that genesis is impaired, because the nerve cells are not being formed, even that leads to a problem with retention. And finally,
Absolutely.
because the registration has not taken place or the retention has not taken place, you cannot recall something which you have not registered. If
Yes.
I'm working on my laptop, if I'm just typing things randomly, if I forget to save the information and I shut down my
It's still
laptop, the
listening.
next day when I open the laptop and I try and locate the document, I cannot locate it because it was never saved. So
Absolutely.
the answer to this question is a loud and resounding yes. Memory does cause problems with attention, concentration, memory, and so on. And so we move
Absolutely.
on to the fourth question.
Yes, sir.
Are depression and anxiety hereditary? I think this we've already spoken about. The
We've
first question
discussed
was,
at length about it. Yes.
so we can skip this because depression and anxiety are just two forms of the disorders that we deal with. And
Yes.
I think now you and I should come to a consensus that for the rest of today's program, let's not worry about using mental versus brain. we use whatever comes, but we know that we are talking about brain
It's
disorders, not
brain
mental.
disorders.
Yeah.
Yes, it just the training makes the vocabulary go in that direction.
Absolutely. So this is a time to start reversing that training, unlearn and then
Absolutely.
learn new things. Okay,
Exactly,
next
exactly,
question.
exactly how CBT works.
Yes,
Uh,
absolutely right. Okay, next question. Can depression and anxiety cause weight gain or weight loss?
Yes, absolutely. I think it's one of the diagnostics. I know it's one of the diagnostic criterias for clinically diagnosing depression is also changes in the weight. Yes, depression and anxiety lead to weight gain and weight loss uh, directly through the biological sphere as well, or the biological reasons as well. Sometimes because of the medicinal intervention also, and sometimes it's because of a lack of enthusiasm towards pleasure seeking behaviors. It's a social withdrawal that leads to is a result of all of these mental brain disorders, and thus the weight gain or the weight loss again can be due to the social implications, due to the psychological implications, or the biological, or even sometimes due to the interventional reasons that come with anxiety and depression.
Brilliant. Absolutely. I think you've covered everything. One of the symptoms of depression is changes in your appetite. In certain
Yes.
kinds of depression, your appetite goes down, which would be followed by a loss in weight. In some kinds of depression, your appetite goes up, and that's going to be associated with weight gain. There are metabolic changes that take place, which also alter your weight. And finally, like you said, the
Exactly.
medications that are prescribed by someone like me, a lot of them would impact a person's appetite and weight. In anxiety,
Absolutely.
if someone has anxiety, there is this entity called comfort eating. Oh, I'm feeling
Hmm.
stressed, I'm feeling anxious, and if I eat something sweet, immediately I start to feel less anxious, because the brain
Absolutely.
remembers that whenever I've had chocolates or barfi or rasgulla or cake, I feel better. So that's
Better.
comfort eating. The more the comfort eating that you indulge in, the more your weight is likely to change.
In,
But
I,
conversely, like
I,
you said, yeah,
I'm
sorry.
sorry for interjecting. Please continue, sir.
Conversely, like you said, in anxiety also you can have, because of all the things that you mentioned, you can have weight loss also.
Yes.
Please go on.
This just was going to add that in the last 2 years, especially with the COVID, we've seen illness anxiety disorder come up greatly. And, it creates a vicious cycle when people come up with what was known as hypochondriasis, and now obviously illness anxiety disorder, that they become so selective in their eating behavior that they start to lose weight. And that creates an evidence for them to say that, oh, something is wrong with our body because we're losing weight. Whereas it's also a result of anxiety driven behavioral pattern of selective eating, not eating junk food, or being overly picky. And I think in the last 2 years I've seen this come up so strongly. I don't think I've ever seen it that as much as in 2 years, that illness anxiety disorder leading to severe weight loss and creating a vicious cycle of creating evidences that supports the fact that they are not well.
Great, very good, very very interesting observations. Let's move on to the next question for today. How is depression diagnosed? Over to you. You can run us through the diagnostic criteria.
So the DSM, with its multiple versions, and in the latest version, is also talking about 8 categories of symptoms, out of which the five should be present to for a period of 2 weeks minimum for depression to be diagnosed. These symptoms can be majority of the day with a depressed mood. It could be loss of pleasure. It could be changes in the weight and appetite. It could be slowing down of mental and physical thought, which is usually not noted by the patient itself, but the environment or the people in the environment. Um, or feeling overly fatigued, feeling worthless, and as we discussed, the loss of concentration and attention abilities in everyday life. So once, if you meet five of the criteria for over a period of 2 weeks, we are able to diagnose clinical depression or a major depressive episode.
Excellent. Very, very good. You virtually run through the entire list. The only two points which I would like to add here, you mentioned feelings of worthlessness. There are two other things which are important for me to mention because they lead to the worst possible consequence of depression, which is
Suicide
suicidal thoughts,
ideation, right?
suicidal attempts. So there
Yes.
is, in addition to all the other symptoms that you've listed, so the person starts to look at the future and he feels that, the future is never going to be
Hopelessness.
any better than my present is. That is a feeling of hopelessness.
Hopelessness.
There is a tendency to compare yourself with people around you, coming out inferior in the process, which is worthlessness. And then you start realizing that whatever you do, you're not able to come out of this situation. That's a feeling of helplessness. This triad is a collection of three things: the triad of hopelessness, worthlessness, and helplessness. it
Leads to
starts
suicide
it
ideation.
starts to escalate, and then the person starts to feel that what is this life that I'm leading? This kind of life is not worth living. And at
Absolutely.
the age of 30, 40, 50, even, yeah, we see suicide at sub 10-year olds now, in adolescents, definitely. So in these age groups, when this thought comes into your head that, life is not worth living, but you're not going to get a natural death,
Hmm.
that is when you start thinking of ways of ending what you feel is this pain, this misery, which has no
Cure.
logical end, no rational end in the foreseeable future. And that is when people start to contemplate self harm.
Yes,
And this,
self-harm
I
and
think, is
suicide ideation.
yeah. So this is the complete spectrum of depression, and this is how you would diagnose depression. This is how I would diagnose depression.
Absolutely, absolutely.
Okay, next question. How is depression different from anxiety?
So this is a very anecdotal answer I can give on this. Yesterday, I was doing a consultation with a small city person who's not very aware with brain disorders, who's not very aware, and he googled me or found something on the website and saw, okay, there was like obviously disorders were listed, and he asked me, इन सब में अंतर क्या है? ये अलग-अलग कैसे हैं? मतलब, there's a general understanding that all brain disorders are similar. Anybody who's feeling sad is depressed. Anybody who's having घबराहट, mostly anxiety and depression are also understood in the similar way, but they're so different. So I told him in the simplest manner that how there is tuberculosis, there is cancer, there is COVID, there is malaria, there are different disorders. In the physical health domain, there are different illnesses in the brain disorders as well, which will have different diagnosable criteria, different symptoms, different etiology of disease will be developed. So it's not that if you say that you're visiting a psychiatrist, you're visiting a psychologist of any form, and you say that it's not just it's just not one spectrum. There are multiple ways and there are multiple disorders. Unfortunately, only depression and anxiety have taken the forefront, but you and I both know that the list goes on in personality disorders and all of these things. So again, anxiety and depression are two forms of illness or two forms of brain disorders with different diagnosable criteria, different symptoms, different etiology and development of disease. For the depression, we've already gone into the list. Same in anxiety disorders, you will find several other sub disorders that are present, which present different symptoms and have different prognosis and outcomes and treatment modalities as well.
Correct. Now, what you've said is spot on. It's absolutely right. But I think the current understanding, definitely my clinical understanding today, is that you have a coin. Ek rupaye ka
Hmm.
sikka, on one side you have heads, on the other
And
side you
one
have
thing.
tails. For me, depression and anxiety are probably two sides of the same coin.
Mhm.
It is just that the manifestations are different, but the underlying pathology inside the brain, the areas of the brain that are involved, the electrical fields that are involved, electrical circuits, the magnetic fields, the chemicals that are involved are almost exactly the same.
Manifestation is
Some,
different.
the presentation is different, maybe because, let's say in depression, this side of the brain is more affected. So we believe that in anxiety, this side of the brain and the right side is more affected, and so on. But really speaking, the presentations might be different, the underlying causation is the same, and so the management of both disorders is pretty much similar. There is a lot of overlap between the treatment of depression and of the different kinds of anxiety disorders. Of course, you
Yes.
need to do fine tuning, but the fact of the matter is
Yes.
that they are pretty much similar with differences.
And they also comorbidly exist with each other, as we see in a long spectrum. When we see a patient for a longer period of time, or when they're coming to us after suffering for a long period of time, we see episodes of both of them coexisting also at most levels.
Correct,
Yes,
correct. That coexistence is that heads and tails on the same
yes,
coin.
the
I
coin.
mean, I can't remember a case of anxiety that I've seen where there is no element of depression. I don't remember seeing a case of depression where there is no element of anxiety.
Absolutely. I agree. I agree to that.
There is predominance. In some cases, the symptoms of depression are predominant. In some, it's the other way around. But
Absolutely.
pretty much interchangeably, we can use both terms.
Yes.
Okay, next question. How is depression different from sadness?
I think, as we've discussed in depression, we've discussed the 8 criterias that we were talking about, and sadness is more temporary, more situation specific response. For example, something has happened and that has led for an emotion of sadness to come up, but it's not a predominant emotion that is occupying, or it's not sustaining for a longer period of time, or not present with the other clinical features that are required to diagnose depression. Sadness is something that we all experience, no matter how unpleasant it is also very, very normal. To state an example, for example, if somebody has passed away, you are obviously going to be sad. That does not make you depressed. It is an unpleasant emotion, it is an unpleasant experience. Obviously, the unpleasant experience is leading to the unpleasant emotion, but it does not entail abnormality or a criteria for a disorder. So sadness is more temporary, more momentary, and goes away, and is you cannot see it affecting, let's say, your eating or your pleasure seeking, or the way that you think about your life, or the triad that you were mentioning. It does not create hopelessness, worthlessness of any form. It does not lead to suicide ideation. Unpleasant but normal emotion, sadness. Unpleasant but associated with any of the 5 or all of the 8 criteria, depression.
Brilliant. I have nothing to say here. It's exactly like what you said about anger. It's a normal emotion. It's just that when it crosses a threshold, then you say that it's a problem. So sadness is a
And
normal
that's
emotion, depression is a disorder, and sadness is just one symptom of the depression.
yes.
Very, very good. Chalo, let's move to the next question. What is postpartum depression?
Postpartum depression is a form of depression that women experience after giving birth. Uh, it is usually, again, the in the triad, the biology matters the most here. It is also very common to experience post-birth blues, as we'd like to call it. Again, if it prolongs the threshold, and if it starts creating an impairment in our everyday thoughts, in our everyday cognitions, in our everyday behavioral functioning, or we have an inability to get out of those blues, then we go and seek treatment for postpartum depression, or we look at postpartum depression, which is uh, directly related to the birth of a child in women.
Absolutely right. So it is a depression which is linked to the time after childbirth. We can also see it after an abortion. We can also see it after a miscarriage. Essentially,
Hmm.
what is happening is that when a woman is pregnant, you know, the hormonal profile inside the woman changes, the estrogen levels, the progesterone levels, and so on. And when childbirth takes place, there is a very, very rapid shift in the level of these chemicals. The same thing happens to a lesser extent after an abortion, after a miscarriage. And this rapid fluctuation in the levels of hormones is what leads to changes in your emotion and mood states. Like you said, postpartum blues is a normal thing. It's like that sadness that we spoke about. It's like the anger that we spoke about. Or you also spoke about sadness after losing someone. You do not call it a depression just because the sadness is there. When it has persisted, for some people say more than three months, other people say 6 months, then we give it the label of a postpartum depression. Essentially, we are allowing this much time for the human body, the hormonal profile, all the other changes that have taken place to go back to a normal state. If it does not happen, that is when treatment or intervention is warranted.
Yes.
Great. What is manic and clinical depression?
I think clinical depression we've covered a lot. In mania, if we were to talk about mania, it's about mania and depression coexist in bipolar disorders. Mania is where there is an experience of uh, irrational enthusiasm or irrational uplifted mood for a period of more than 3 weeks. This is not just feeling good, but it is to a level where it is abnormal that leads to mania. And depression, I think we've discussed. Manic episodes also exist within depression cycles sometimes, and if it prolongs for more than 3 weeks and if it happens in a cyclical fashion, then we are going into the tragedy, into the areas of bipolar disorder.
Correct. So you're right. We've discussed depression. We don't need to do that now. You use the term bipolar. Why do we call it bipolar? If this is
Because
the
there
equator,
are
if
two
this is
ends
a
of
globe,
the.
correct. So if this is the globe of the earth, like we teach our children, this is the globe of the earth. ये बीच में equator है. So the southern hemisphere is like this, which is the equivalent of depression. If the exact opposite takes place, it's the northern hemisphere. And if you superimpose the northern hemisphere on the southern hemisphere, you have two poles. There's a north pole, that's the south pole, and that is why we call it a bipolar disorder. And the
Yes.
northern hemisphere with the symptoms associated with the reverse of depression, very very cheerful mood, elated mood, full of energy, racing thoughts, feelings of grandiosity and so on. Those are the features of the manic episode.
Episode. Yes.
Okay, next question.
I really like this idea of the Google search, I must say.
Excellent, excellent, I'm really enjoying this. How does depression affect the brain?
I think again we've gone at length when we've talking about the toll that depression takes on our brain. It's the memories, the nerve cells. There are multiple. It doesn't happen in isolation. There's a correlation and there's a coexistence of a lot of consequences of these brain disorders that cannot be just said as one thing. Like even for that matter, COVID and today, as you were rightly saying, that there's eye twitching, which we never thought. Initially we thought cough, cold, fever, and now we know that okay, rashes, eye twitching, so many more symptoms, loss of taste, all of these symptoms are also coming up. And in the same way, I think depression also has such a magnitude of effect on the human body that uh, yes, there is a list that of implications that are there, obviously affecting on memory and on our weight, about cognitive functions, about concentration, about attention. But I think the list can be over expanded at any point in time. To understand how depression is affecting our brain, because with the new technology that's going to be coming up, with the new kind of scanning that's coming up, we're seeing more and more changes, we're seeing more and more growth into understanding how depression itself is evolving and how it's taking a toll not only on our brains but our entire bodies for that matter.
Correct. Absolutely right again. You are a great fun for narrating anecdotes. I'll also narrate an anecdote here. Let's say I have a very fancy car. I have a Ferrari or I have a Lamborghini or something. How does that car run? There's automatic shift. You put it into drive. You press the accelerator. The car moves forward. When I want to stop it, I press the brake, and the car stops. In depression, what is happening is that I may have the fanciest brain that anyone has ever had, but depression means trying to drive the car with one foot already on the brake. Essentially, it is a slowing down of all the functions inside the brain. Now, it can be explained in the context of the neuronal damage that you spoke about. There are other cells which could be damaged. There are a lot of electrical circuits inside the brain which could be damaged. But the relationship is that of cause and effect. The problems in all these things cause the depression, and depression in turn will make these things worse until the treatment starts and you put a halt on the depression, which means you help the person to lift the foot off the brake.
Of the bed. Yes, I think in all these brain disorders, there is such a creation of vicious cycle. The symptom leading to a consequence, the leading to a disorder, then the disorder itself leading to a symptom, and then a consequence. It's a vicious cycle that has to be broken if proper treatment, is employed.
Right. Okay. I think let's take one last question. We've already shot past the time limit. What are some common mental disorders?
Brain
You're,
disorders.
you go on and on with this list, but
I know. I think let's divide it into like to quickly make people understand. I think anxiety, depression would go on in all areas and all genders and all age group that we can talk about. In children, we are seeing a lot of ADHD, which is attention deficiency hyperactivity disorder. I'll quickly go through it, which causes inattention, hyperactivity, and again, impulse control. That there is a developmental mismatch or the age maturity or social maturity mismatch. We are seeing a lot of personality disorders. I'm sure that they have been existing, but the awareness have become much more higher. Borderline personality disorders, narcissistic personality disorders. These are the two things that are coming up in my clinical practice a lot these days. And I know for a fact that borderline is one of the most difficult to diagnose as well. But I am seeing, I think around like 5% of my population is suffering with BPD and I take around 3 to 4 months to diagnose it itself, to be very honest, to be sure of my diagnosis. Anxiety and depression are always there. Illness anxiety disorder, previously known as hypochondriasis, where you're very particular of where your health concerns are at the level of anxiety, are something that have come up a lot in the last 2 years. And OCD is obviously on the rise. Again, I am not sure to claim whether they're on the rise or there is better mental health access or awareness that people are coming up to us and discussing these problems. But OCD, personality disorders, ADHD, anxiety and depression always present, but these are the most common, or at least the most seen in the recent times in the clinical practice.
absolutely. I would just like to add, substance use, substance dependence disorders. There are so many chemicals that are available on the streets today. I mean, earlier people used to be worried about smoking and cannabis and so on. Now you go onto the street, you can get, I mean,
Anything.
I test for 23 different drugs in my clinic laboratory. So you can
Okay.
get opiates, which is heroin, morphine, fentanyl, oxycontin, codeine, the works. Then you have
Yeah.
ecstasy. You have, I mean, the list is endless. And of course,
Endless.
you have alcohol. One of the
Yes.
commonest problems that we expect to encounter, alcohol dependence or alcoholism as an independent primary entity, and also as a disorder which coexists with a lot of other disorders that you have mentioned.
Absolutely.
So the list is
Absolutely.
endless. I think we need to do another few such shows to justice to all of them. And
Yes.
I think that would be an end to the questions for today. Would you like to sum up for us what mental disorders represent in today's day and age?
uh, Brain disorders
Brain
is
disorders.
something. I'm rewiring myself already. I think we have to see that when we talk about brain disorders, uh, the first thing that we have to do is we have to destigmatize ourselves or our patients as well, who live with such conditions. We don't have to worry about the public or the social perception. It's very important to start, as I'm aware that this show has a lot of physicians and a lot of medical practitioners as viewers. I think it's very important to understand these disorders, to get these people the right kind of comprehensive health care over the interventions that they require. Secondly, if one of us is also suffering, let's not do that in silence. Let's understand that brain disorders are nothing but an impairment to our everyday functionality, our potential to achieve, our capability to achieve our potential. And if there is a impairment in your thoughts, if you're in your behaviors, in your emotions, in your productivity, then forget about the label, forget about the diagnostic criteria, and seek help, seek support. Because sometimes it's not only about, वो कहते हैं ना, समझाने की जरूरत नहीं होती है अपने आप को या अपने पेशेंट को, but कुछ चीजें सीखने की भी जरूरत होती है. The way that you taught me to rewire, to call mental disorders brain disorders, there is rewiring can happen in multiple ways, and we can provide help, and there's a lot of accessibility and a lot of good care available now. So let's make use of it for
Wonderful.
ourselves, our families, and our patients as well.
Wonderful. If there were any other questions that had to be Googled in your answers, you answered those also. Very, very good.
Thank you, sir.
Thank you so much for being with us today, Jaya. We have a certificate for you, which is coming up on the screen right now.
Oh, thank you so much, sir.
Great.
Thank you so much.
So,
Thank you,
folks,
sir. It was a pleasure and an experience to speak with you.
Thank you. Thank you so much. And that's all for today. Dr. KK's Med Talks will be back tomorrow at 7 p.m. with another edition of the show. And please do stay connected with us. Namaskar.
Good day. Goodbye, everyone.